All right. Switching gears now to PFIC2. Um, so in many ways, transplant for BSEP is essentially you just transplanting a protein. Unfortunately, it requires an entire liver around it for it to work. The new protein that is included with that liver is exposed to the blood, and so it's on the canalicular membrane. It's the product of the gene, and it is new. It's new to the patient. It's not been seen before by patients that have BSEP deficiency. It's normal to have. It functions, and that's why you do a transplant. However, the actual protein has not ever been expressed in that patient before. In response to that, just like anything else, you can develop an antibody response to BSEP, and it's just another antigen or just another piece of protein that you can develop an antibody to. And so when was this described? How did it really kind of how was it really noticed? It was a syndrome back in 2009, and so it was really described in a single patient. And what the patient saw was that they started to develop pruritus and cholestasis, so they started to become jaundiced after a liver transplant for PFIC2. Interestingly, after liver transplant, if you're going to be cholestatic and jaundiced, one would expect your GTP, which is a marker of bile duct damage, to be very elevated. And so indeed, we follow GTP after liver transplant as a sign for bile duct stenosis or injury. This patient developed cholestasis with high levels of bilirubin in the blood, pruritus, and their GTP was normal, which was exactly as one would expect in a patient who had primary PFIC2. And so it actually they did a fairly extensive workup, and when you read this description, they did a real long transplant workup before they checked the bile salts. And I think when they found that the bile salts were as elevated as they were, they suspected that maybe this is a recurrent disease. And so in the initial thought is maybe this is an issue with the donor, but indeed they eventually went on to find that there is antibody both on biopsy and in the blood. And so here is kind of what they did as a general workup. You can see on the right hand side, they did a liver transplant. They had a clinical symptom, and you can see in the kind of pictures below that the actual deposition of antibody, and they actually typed that antibody to show that it was anti-BSEP antibody. And autoantibody in this and autoimmune, and it's not really autoimmune, it's alloimmune. The protein is not the own patients. It's so, when you develop an autoimmune disease, you develop a disease against, say, your own islet cells, so you develop diabetes. These are alloimmune, and it is a little bit there is some differentiation there in that alloimmune processes can sometimes be easier to treat than autoimmune. And that's not saying that this is in any way easy to treat, but I think that it's there is some degree of the ability to treat this and to exhaust the immune system against an alloimmune process much more than it would be if it was an autoimmune process. This is the group that published the initial, it really didn't project well, I'm so sorry, published results from 11 other patients that all had this PFIC2 recurrence. This is it was a multi-center look at these patients. They were all found to have no BSEP antibody expression pre-transplant. They actually had serum that they checked for the antibody, and they found it post in most of them, and they were able to actually analyze post. Most of these patients had symptomatic recurrence of the 12. It was really the time between the transplant and the development of symptoms ranged quite a bit. But it was in the area of I think the earliest was a few months after transplant, and the latest was 12 years after transplant. And so there's a big variation as to when this can happen. And so it's a clinical syndrome. When you look at the overall numbers, it's about 8% of the transplanted patients for BSEP disease. Again, it's a small population of patients. It's really hard to tell, if that 8% is accurate. But in patients that it starts, or at least in the history of this, it tended to recur after retransplant. And it makes sense when you consider that, the antibody that is generated against normal BSEP protein. And so unfortunately, that BSEP protein is going to be very similar in every patient that has a normal BSEP. The only patient that wouldn't have a normal one would be somebody that had, PFIC2. And so these do recur after retransplant. There have been patients transplanted 3 and 4 times for this. But it's important to realize that there are things that can be done. And so there is an accumulation of data over time about this, about these diseases and about this issue. And so one of the good things is that this alloimmune kind of recognition is similar to that as seen in solid organ transplant, and ABMR as antibody-mediated rejection. It's seen in rarely in solid organs, but it's certainly seen in heart transplant. It's certainly seen in kidney transplant, but it's well studied, and there are drugs kind of in development for this type of recurrence. Of course, everything that you do to immunosuppress somebody has its own side effects and can lead to all sorts of complications. But I think that because of the data that is accumulated over time with antibody-mediated rejection, the treatment paradigms and kind of the treatment protocols are starting to be developed for this and are not as foreign to transplant surgeons and liver transplant surgeons as they were, say, 15 or 10 years ago. And so there's a slew of anti-metabolite drugs that can be utilized to decrease antibody production. Once antibodies are made, one of the ways you can downregulate the cells that make them is with plasmapheresis. And so you drain all of the plasma out of a person, and at the same time you replace it with frozen plasma. And so you essentially draw out all of the antibody and many other things along with the antibody that is there, and replace it with serum that does not have it. That over time can what you would say is exhaust the cells that make these antibodies, and can lead to treatment and can lead to kind of a remission in this issue. Bortezomib is a drug that has been used quite frequently in intestinal transplant and renal transplant. Bortezomib is a proteasome inhibitor. It's a drug that actually the cells that make antibody are called plasma cells. Bortezomib is used, or was initially used in a type of cancer called multiple myeloma, which is a cancer of the plasma cells. And bortezomib works to inhibit the production of antibody from those cells. And so that when you inhibit antibody from a plasma cell, you actually downregulate the plasma cell, and it gets rid of the kind of clone of plasma cells that make that antibody. Bortezomib has been used extensively, has not been used to my knowledge in patients that have BSEP recurrence, but it's certainly something that should be. And then bone marrow transplant seems severe. It seems like something that would be a major undertaking. However, if you have a patient who had a liver transplant who needs another liver transplant, who could very well need another liver transplant, bone marrow transplantation at the time may actually lead to a kind of a more long-term cure, especially if there's living donor options where you could do a well-matched bone marrow and do a well-matched liver from that same person. It would actually be a way to ameliorate all of the production of antibody against the new liver. And that's really the only way to completely do it. This has never been done, it's never been tried, but it's certainly something we've talked about in the past clinically, and I'm sure has been talked about in other centers. And so patients with PFIC2 often require a transplant earlier than those with FIC1, The extrahepatic complications, thankfully, of PFIC1 are not present in these, but unfortunately, the disease can recur, and patients really must be monitored quite closely for that recurrence of disease. One of the probably the easiest way to do that is to monitor bile salts, as the GTP is not going to elevate. You can monitor bile salt levels in patients, and obviously, when you get routine liver function tests, you check the bilirubin, but the bilirubin may be a later finding than, say, the bile salts. My only caution to that is that you need to find out what the normal or the patient's bile salt level is early after transplant, because sometimes patients with PFIC1, PFIC2 can have elevated bile salts, mildly elevated bile salts after transplant, even those that are doing well that don't have any recurrence, even in the first few weeks after transplant.